I'm here today with Ken Lund, President and CEO of Shea Family. Thanks, Ken, for joining us.
Thanks for having me.
Ken, you've had some massive successes and experience with navigating through the accountable care organization in California. Could you tell us about that journey and some recommendations, some things that you've learned, some things that you want to share with us on recommendations for future negotiations? That we'd be grateful for that.
We started the process probably 5 years ago, and it was really before ACOs were really a big part of the national conversation. But we started with the idea that we were primarily a custodial skilled nursing company, and we knew that wasn't the future. Even at that point in time, it was marginal at best. And so I came from the continuing care retirement side of the world and the independent living, the assisted living. And so as what we went down the road of doing was developing a continuum of care, because we knew based on that experience that population management, we thought at least, was the future. And so in the San Diego marketplace, Sharp was the first pioneer ACO and the only pioneer ACO in the San Diego marketplace. We'd already developed a continuum that wasn't just skilled, but it was assisted, it was home care, home health care, transportation. It was a full continuum. And we had a radically different approach to admissions, to billing, and to case management, all of which fit into what their goals were: significantly reduced readmission rates, higher customer satisfaction, shorter lengths of stay, those types of issues. And so in having that model ready to go and willing to go at risk by guaranteeing outcomes, we were able to secure a virtually exclusive contract for the managed care and ACO patients.
So you had the market and you had the continuum of care, which not a lot of organizations have the luxury of having that. So we had the admission to the SNF, then you had the outpatient or the home care, and the transportation services. Now, how did that reflect from a census perspective? Meaning, did your average daily census for your Medicare Part A population go up? And if so, how much did it go up?
Our Medicare A census went down over time.
It did?
It went down by about 20%.
Fascinating.
And there are anecdotal reasons for that we can talk about. But in large part, I think, if I can segue, I think is what I'd talk to is what we learned in the process. Great. Because we absolutely believed that when we cut readmission rates from the high 20s down to single digits, when we took average length of stay, in our case, our average length of Med A stay 4 years ago was 31 or 32 days. Our average length of stay across our system right now is somewhere in the 10 to 12 day range.
Wow.
And when you look at mortality rates, nobody talks about mortality rates, but it's an important number to look at, because if you're bringing your rates down and your readmissions down, but your people are dying in the process, obviously not a good outcome. Yeah. Our mortality rates are 5 times better than the national, state, and local average. So all those metrics combined, we absolutely believed that the Medicare, when the hospitals and the case managers, discharge planners saw those outcomes, that we would be flooded with Med A patients. And the reality is that didn't come to fruition. And one of the other things that we learned was that when you reduce the daily rate, if you will, because we took a bit of a haircut in the daily rate, and you reduce the average length of stay by 50% or more, and you reduce the readmission rate, the reality is we were getting about 35 cents on the dollar compared to a Medicare Part A patient. So in San Diego, a Med A patient on average was maybe $18,000 in revenue per episode. A managed care patient was between $4,000 and $6,000 with equal or better outcomes. We had zero slippage on our outcomes. So what does that mean? It means we needed a ratio of a minimum of 3 and preferably 4 to 1 for managed care patients for every Medicare patient that we were replacing. And that's a tall bill to fill. And what that also means is if you were below capacity in your marketplace, so in San Diego marketplace, it was already overbedded in a traditional market. If you cut that readmission rate and you cut the average length of stay by 50%, guess what? You've got 50% over capacity. So when we talk about driving volume, it's not that anybody's trying to be greedy, it's that you understand just through the life experience that if you don't have that volume, and it's the same problem Kaiser or any of the other large managed care players that have been in it for 50 or 60 or 80 years, they learned early on, it's a volume model. It's not good or bad, it's the reality of the situation.
Agreed. So give us a couple of tips for those, across the country that are now in negotiation or in a geographical region that warrants or the necessity for interaction with an ACO. What can you tell the C-level because you're advanced, you're in the West Coast, you've done this before us on the East Coast.
If I were to do this, if I'd never done this before and I was coming into it, first of all, I would absolutely positively know my numbers cold. Mm-hmm. And not only, for example, with readmission rates, we always talk about this gross readmission rate. And the information's available to be able to drill down by diagnosis. It blows the managed care companies out of the water when you come in and say, yeah, here, ours is better than everybody's. But by the way, looking at your population, we know that if we focus on COPD in this particular facility, we're going to be able to save you enormous amounts of money and provide better outcomes for your patients. The information's available to drill down. So first of all, know your numbers going in, because they're going to think they know your numbers and they're going to misinterpret them because they don't know your business. If you don't know going in, you're going to sit there and just look silly. Secondly, you have to understand that it is absolutely, positively a different business. Because while I've got a lot more skilled patients today, the ortho patients is who we used to have in Med-Aids. They go home now through the managed care plans. And they go home with home health care. So the people that we're getting in the buildings have a whole bunch of things wrong with them. They may have some ortho, but they have lots of things going on. So they're clinically complex, and under a Medicare model, they would have had a very long length of stay. Under a managed care model, they may only stay 6 or 8 or 10 days, but they're still going home with home health. So part of that is you need to learn that, first of all, you're not going to survive on custodial. Get that out of your head. In California, we're already offering an assisted living model under the dual eligibles program, for example, that saves 40 to 50% compared to a skilled custodial and still provides a better environment and comparable outcomes. So if you're the state, you get a better environment, a more home-like environment for your patient, and you also save 40% in the process. Where are you going to go? It's a pretty easy decision.
Ooh, tell me a little bit about this assisted living. Are you referring that or stating that the state-funded assisted living stay, or is it all private pay?
No, it's absolutely not private pay. Under California's dual eligible program, they take a chunk of money and they give it to a managed care company and say, on a risk basis, these are now your patients, your customers. And they have allowed the managed care companies to contract with third-party providers like us for the post-acute continuum. So one of the things we've done is we've gone to the managed care companies and said, look, if you've got custodial people and skilled that are truly custodial, we also have an assisted living product. Move them over there, save 40%.
But that's your idea.
Absolutely.
That's your idea.
And
that's not happening.
Well, skilled nursing hates the idea because that sucking noise you hear are the custodial patients leaving skilled nursing. But that goes back to population management. If you're a custodial player, that time bomb you hear clicking is in your back pocket. You're out of business.
But what's going to happen is that if this indeed comes to fruition and the transfer of the percentage of patients goes into the assisted living, those assisted living entities are going to have to learn how to care for the patient in a different
just
format.
Like I had to learn how to care for higher acuity patients in skilled nursing.
Agreed.
Now the next evolution of that is going to be pushing them out of assisted living and into independent living.
Yes.
And one of the things with one of the managed care providers we work with in San Diego, we've even talked about literally how do we deliver in-home services to somebody living in a car, living in a park, living under an overpass, because the services are still needed.
Yeah, it's a great point. Wow, well, this has just been very enlightening, and we're very grateful. Thank you so much today for joining us.
Thanks so much for your time.